Good evening. It is great to have so many of you from across the country join us tonight for our webinar on research updates from the recent American Society for Clinical Oncology, referred to as ASCO, their Genitourinary Cancer Symposium. This webinar is brought to you by Xero, the End of Prostate Cancer. I'm Jeremy Patch, Director of Patient Programs and Education here at Xero, and I'm serving as the webinar host. I want to thank our featured speaker, Dr. Alexandra Sokolova, for sharing her time and expertise with us today. I will introduce Dr. Sokolova shortly. Before we begin, I'd like to go over a few housekeeping items. Today's webinar is being recorded and will be posted on our website, xerocancer.org, tomorrow. As soon as the webinar ends, you'll see a link to our survey, and we would love for you to participate so we can get your feedback on this event. Tomorrow, you will also receive an email with a link to the recording and the survey. Speaking of surveys, Xero is partnering with Duke University researchers and Pfizer Oncology to better understand the needs of prostate cancer patients. Those survey results will help build programs, develop initiatives, and improve patient access in order to produce better outcomes for all people impacted by prostate cancer. Go to xerocancer.org to learn more, and we'll also be dropping the survey link in the chat box. For those of you not already familiar with Xero, we are the leading national nonprofit with the mission to end prostate cancer. Xero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. We offer an extensive portfolio of patient support programs and educational tools that are offered at no cost to patients and families. If you or someone you know is in need of resources at any time while facing prostate cancer, please share these resources and let them know we are here to help. I'd like to spend just a moment to highlight a few of our support programs. Xero 360 provides individualized case management to help patients and their families connect with financial assistance, navigate insurance, and find other kinds of support, including emotional support and transportation assistance. Xero also offers peer-to-peer support through our mentor and caregiver connector programs. We match patients and caregivers with peers who've had similar experiences to provide ongoing one-on-one support. Xeroconnect is our online private Facebook support group where you can connect with others affected by prostate cancer, learn from their experiences, and ask questions from patients and loved ones across the country. Our Us2 support groups are the newest addition to Xero's programming. Support groups are offered all over the country and provide a space for people to connect with others in their community. Virtual support groups are also available, as well as those for caregivers, Black men, gay men and their partners, deaf men, and Spanish-speaking men. On Xero's website, you can find a variety of our educational resources, including questions to ask your doctor, patient guides, and up-to-date content on the latest in diagnosis and treatment information. There you can also find a nationwide database of sites who offer free or low-cost prostate cancer screening. We also have a full calendar of upcoming educational events. In May, Xero will be hosting a two-part webinar series taking place on May 10th and May 19th. These webinars will discuss side effect management and risk mitigation, as well as treatment advances. A registration link to these events will be in the follow-up email to this webinar, or visit our website at xerocancer.org to learn more. Today's webinar will be led by Dr. Sokolova, who will provide us with a few exciting updates from the 2022 ASCO GU meeting held earlier this year. We will then take questions from our audience, so please feel free to type your questions at any time in the Q&A box located at the bottom of your screen, and we will do our best to get to as many as we can. Now it's my pleasure to introduce Dr. Alexandra Sokolova. Dr. Sokolova is an assistant professor of medicine in the Division of Hematology and Medical Oncology for the School of Medicine at Oregon Health and Science University and has a specific interest in prostate cancer genetics. Thank you so much, Dr. Sokolova, for joining us today. We are excited to hear from you.
Hello, everyone. Thank you for this warm introduction. I'm honored to be here and be able to share some exciting news that are presented at GU ASCO this year in San Francisco. And I should be able to advance the slides. Yep, it's working. So what we're going to do today is I'm actually going to take you to the same experience and front row experience as if you were at the conference. I'm going to share the slides that were presented at the conference. I'm going to try to explain them in a very patient-friendly way. And if you have any questions, we'll make sure to leave plenty of time at the end to talk about it. So what we'll talk today about is 4 studies that were presented during the oral abstract session. And this is the session that the highest yield research studies are selected for. Those are abstracts that have the most time dedicated to them discussion and are considered potentially to be the most impactful and meaningful. So those 4 studies that were presented at oral abstract session at GU ASCO were first in metastatic hormone-sensitive prostate cancer, ARISON study looking at docetaxel plus darolutamide. And then there were 3 studies in metastatic castration-resistant prostate cancer. Prostate study looked at docetaxel and enzalutamide as a combination therapy, and then propellant magnitude looked at PARP inhibitors and abiraterone. And as you can see, the overall trend of those studies that we're looking at intensification of therapy. Can we combine therapies to achieve better outcomes and prolong life of our patients? And then at the end, we'll very briefly talk about Pcma, both imaging and therapy. I know a lot of you are probably going to have questions with lutetium being approved, so we'll briefly touch base on that, even though the vision was presented now 9 months ago. So because I am taking you to these kind of research-heavy slides and PowerPoints, I want to give you a very quick crash course in statistics and how we evaluate the results of the study. So when we talk about treatment of metastatic cancer, we have 2 goals. First goal is to prolong the life of our patients. And the second goal is to improve the quality of life. And when we have a new drug or we design a study, we try to answer the question, does this drug help us improve quality of life? And does this drug help us prolong the life? So in answering the prolonging life question, we use the term overall survival. And the way they present overall survival data is those graphs. And so I just want to walk you through those graphs because you're going to see a lot of them. So when we talk about overall survival, on the bottom, you're going to see time, and that's usually in months. And on the left, vertical axis, you see % of patients surviving at a given time point. And usually have 2 groups, usually a control group and a study group. And so you see that at 0 time point, 100% of patients were alive at both groups. And as the time goes by, at 20 months, that's probably about 40% and about 60%. And that at 40 months, the difference is even further. This is probably 45 and 15. And so the line that's on top means those patients are living longer and doing better. So on top is good. And the more there is gap between those 2 lines, the more there is added benefit, meaning this group number 2 did better than group number 1. And the measurement of how much better is kind of how far those lines behind. Oops. And the other term we use is median overall survival. And that's basically, we take those graphs and we cut it in half. So we choose a 50% and we cut it. And we say that in group 1, 50% of people survived 10 months. And in group 2, the 50% of the people survived 25 months. So this is our way of comparing just kind of a middle of it. So meaning half of the patient lived longer, half of the patient lived shorter, but we compare the 2 medians. And this is also how we compare overall survival and the benefits. So prostate cancer is a very important problem. It's the most common non-skin cancer among men in the United States. In 2022, over 268,000 men are estimated to be diagnosed with prostate cancer. and over 35,000 are estimated to die from prostate cancer in 2022. When we think about prostate cancer, we think about it as stages, localized versus metastatic. So on the left, the localized prostate cancer is when the cancer is still within the prostate, it hasn't spread beyond that. And the treatment options include radiation or surgery. And once man has definitive treatment, radiation surgery for localized prostate cancer, they could develop what's called the biochemical recurrent prostate cancer. And that means that after the surgery radiation, the PSA is rising, but on imaging, we don't know where it's coming from. We don't see cancer on imaging. So that's kind of the term biochemical recurrence. So the PSA is rising. We know there's cancer cells somewhere there, but we're not able to find them on imaging, CT scan or bone scan. And from the treatment options for this disease space are observation or intermittent testosterone suppression therapy or androgen deprivation therapy, ADT. From that space, the disease could progress either to non-metastatic castration-resistant prostate cancer. What that means is that we still don't see metastasis on conventional imaging, CT scan or bone scan, but the cancer has stopped responding to the first line of hormonal therapy. And so castration-resistant term means that the cancer has stopped responding to the first line of hormonal suppression therapy. Or the cancer could become metastatic hormone-sensitive prostate cancer, meaning we know where metastases are, and the cancer has not stopped responding to hormonal therapy. And the most advanced setting is metastatic castration-resistant prostate cancer. We know there are metastases, and the cancer has stopped responding to the first line hormonal therapy. We'll spend majority of the time talking about the metastatic castration-resistant and metastatic hormone-sensitive, and then we'll briefly talk about the new imaging modality in that space. And on the right, you see the treatment options available right now for prostate cancer. And so we have 4 AR-targeted androgen receptor target agents, abiraterone and enzalutamide, apalutamide, and darolutamide. We have 2 chemotherapy agents. We have 2 immunotherapy agents. We now have 2 PARP inhibitors, which are targeted therapies, and we have 2 radiopharmaceutical, radium-223, and the newly approved lutetium. And so moving forward, we'll talk about the first study, ARASENS, that was done in metastatic hormone-sensitive prostate cancer. So, and ARASENS looked at docetaxel and darolutamide. And this is a little bit of kind of history of what did we used to do in this disease space. So those are patients who either had treatment for localized disease and then they presented with metastasis, or newly diagnosed patients with prostate cancer that were found to have metastasis. For a long time, we would just treat them with hormonal therapy, androgen deprivation therapy, Lupron, Luprolide, Degarelix, Eligard. And that was the treatment, and we continued them until they progressed. And you see this on the left, the study from 1998, when that was the standard of treatment. And at that time, the median survival was 30 months for those patients. The paradigm really shifted in 2015 when the data came out saying that if we add docetaxel to ADT in a first line, that really helps our patients live longer. And so again, we see months on the bottom, percent of patients surviving, and you see the green is docetaxel on top and ADT alone on the bottom. And so the median overall survival with docetaxel at that point was 57 months versus 44. So there was over a 10-month benefit with adding docetaxel in a first line of metastatic hormone-sensitive prostate cancer. And that really changed how we treat those newly diagnosed metastatic prostate cancer cases. And so docetaxel was the first one to be evaluated and shown benefit in intensifying treatment in the beginning, followed by abiraterone in 2017, and enzalutamide and apalutamide in 2019. And now we have a new data saying that while actually doing 3 agents in certain scenarios could be better than just doing 2 agents. And so we're not going to talk a lot about piece 1 data that was presented at ASCO last year, but this study looked at doing docetaxel in a newly diagnosed patient, and right after they're done with docetaxel, adding abiraterone without waiting for disease progression, and it showed improved overall survival. And then in GU ASCO of 2022, Arison's data was presented, and they tested using docetaxel plus darolutamide together, also showed improvement in outcomes for the patients. So Arison's study, on the left, we talk about which patients went into the study. Those who were metastatic hormone sensitive. ECOG is the way we measure how fit patients are. It means that 0 is people who are healthy, can do really hard work, standard exercise activity, and going all the way to 4 for patients who are really bedbound and not able to do much. So 0 to 1 are fit, very fit people who are able to be active, and they had to be candidates for docetaxel. So this study really selected men with newly diagnosed prostate cancer who were fit and were thought healthy enough to go undergo docetaxel chemotherapy treatment. And they were randomized to either docetaxel, 6 cycles with darolutamide, which is an oral androgen receptor targeting agent. So it works in a synergy with the shots, with hormonal therapy to kind of help lower the effect of testosterone even further. It blocks androgen receptors, what testosterone binds to. So docetaxel with darolutamide or docetaxel plus placebo. And the question the study asks is, does adding darolutamide to docetaxel helps patients live longer? So the primary endpoint was overall survival. The study also asked important secondary question, kind of secondary endpoints, which I think are very meaningful for our patients. It's time to castration resistance, time to pain progression, time to skeletal events, meaning fractures, and time to the first skeletal event, time to initiation of next treatment, time to worsening of disease symptomatically, and time to initiation of opioids for pain. And Arison's met its primary endpoint. It showed improvement in overall survival and decreased risk of death by 32%. So on top, you see the yellow line is the patients who were on darolutamide plus docetaxel, and on the bottom in green, men who were on ADT, docetaxel, and placebo. And at 48 months, it was 62% survived versus 50% survived. So it really showed improvement in overall survival for those men. It also showed improvement in their secondary endpoints, which we discussed earlier. So not only it improved the survival, but looks like it improved the quality of life because time to pain and time to skeletal events was improved as well. Another way we look at quality of life and how our new studies affect the quality of life for patients is we assess the adverse events, and that means the side effects of the therapy, and we grade them, with 1 being the least bothersome and 4 being the most bothersome. So this is the table comparing those adverse events in both arms, and it only includes those 3 to 4 that were a little more bothersome. And 66 and 63% had at least 1 grade 3 or 4 adverse event. However, when we compare both arms, they are more or less similar. You could notice that hypertension was more common in darolutamide arm, increased blood pressure, and that's because it's a common side effect for darolutamide. And you can see that liver enzymes were a little more often elevated in darolutamide arm, again, because this is an oral drug, and one of its side effects is potential to elevate liver enzymes. But other side effects such as neutropenia or anemias, which likely driven by docetaxel, were similar in both groups. So what does it mean for patients and clinicians who see patients in the clinic? I think that this triplet regimen of ADT, docetaxel, and darolutamide is a new standard of treatment for men with metastatic hormone-sensitive prostate cancer in certain clinical scenarios. And I think when we think, well, which patient could benefit, is that a good fit for that particular patient? We should be thinking about the spread of the disease and kind of the pattern of metastasis. In this study, most of the patients had metastasis to visceral, such as lungs or liver or bone. And we also need to look at the fitness of the patient, because this study enrolled quite fit and healthy patients. So evaluating fitness of patient for this combination therapy is also important in deciding if this is the right fit for a particular patient. We're now going to move on to the second oral abstract, a study called Prostate, and that evaluated docetaxel and enzalutamide. And this study and the rest of the kind of other two abstracts we're going to talk about are focusing on metastatic castration-resistant prostate cancer. So we know there are metastases and the cancer has stopped responding to the first-line treatment. And this is a landscape of treatment for mCRPC, metastatic castration-resistant prostate cancer. Docetaxel was shown to improve survival in 2004. Provenge and cabazitaxel were approved and shown to improve survival in 2010. Abiraterone came on board in 2011. Enzalutamide in 2012. Radium 2013. And then we had almost 7-year gap without new therapies approved in that disease space. And then in 2020, we have two PARP inhibitors, olaparib and rucaparib, approved. And most recently, we have lutetium Pcma approved in that space. And so the Prostate study looked at men who received enzalutamide and who progressed on enzalutamide and kind of looked into treatment options after that. So this is a study schema for Prostate clinical trial. And they had an interesting design. So they looked at men who had metastatic castration-resistant prostate cancer who went on enzalutamide therapy. And at 13 weeks, they evaluated if patients were responding or not. And those who were not responding, measured by PSA or scans, did not proceed with the study. So they were taken off the study. But those who did respond to enzalutamide in those first 13 weeks continued on the study, and then the study team followed them until progression. And once they progressed on enzalutamide, they were randomized to either start docetaxel and placebo or continue enzalutamide along with docetaxel. So the question the study is asking, if patient had a nice response to enzalutamide and is now progressing, and we're planning to start docetaxel in this patient, should we stop enzalutamide, or is there potential benefit on continuing enzalutamide while adding docetaxel? And this study did not ask a survival question. They asked, the question is, does this combination therapy helps to improve progression-free survival? And so progression-free survival means the time period from when we start therapy until there is a disease progression. And in this study, it was measured by either things looking worse on imaging or a patient clinically doing worse. So clinical or radiographic progression-free survival. And so the question of progression-free survival is a little less impactful than overall survival, because we know that our goal is to improve quality of life and improve survival for patients. And progression-free survival is a surrogate endpoint, and we use it as a signal and to gauge our thoughts about developing new treatments. But there have been scenarios when treatment improve progression-free survival, but do not improve overall survival. So we don't want to blindly accept that improved progression-free survival means that there's going to be improved overall survival. There's a little bit nuances of which endpoint we use for our studies. So the first study used overall survival, and it answered that question. This study answers progression-free survival, so a little bit of a surrogate question. And it met its primary endpoint, meaning continuation of enzalutamide improved progression-free survival. So the median time was 9.5 months for enzalutamide versus 8.2 months for placebo. So on average, meaning 50% of people who were in the study had about a month benefit of progression-free survival with continuation of enzalutamide versus stopping and starting docetaxel. When we look at safety data and adverse events, though again, very comparable between two groups, because a lot of them were probably driven by docetaxel. You can see that fatigue or asthenia were more common in enzalutamide versus placebo. That's common side effect of enzalutamide, but other side effects were more or less comparable. So what does this study mean and how do we interpret that? I think that continuation of enzalutamide is an option in certain patients. And I think that could potentially be used in someone who has a benefit from enzalutamide and maybe continues to have benefit from enzalutamide, meaning we do the imaging and there is mixed response. Some lesions continue to get smaller and respond, but maybe some lesions are not. So we think there is still clinical benefit of continuing the therapy, then continue that and adding docetaxel could be an option for these patients. It's important to remember from this study, men did respond to enzalutamide initially, and they progressed in the first 15 months, and they had ongoing benefit, and they were fit for this combination therapy. So those are important points to consider when we have these discussions in the clinic, whether or not this is the right treatment for a particular patient. Now moving to the next two oral abstracts, which used PARP inhibitors, PROPEL and Magnitude. But before we go into those studies, I want to give you a little overview of what PARP inhibitors are and how do they work, because they're now FDA approved, and we're going to see probably more data about PARP inhibitors coming out. So our body consists of organs, and each organ consists of a cell. And in the cell, in the nucleus, there is kind of a command center that has all the information coded in the DNA. And you can think about DNA as a code or recipe book that has instruction for each cell, what it's supposed to do, what it's supposed to build, how it's supposed to interact with other cells. So this is kind of a blueprint or instructions or recipe book that tells the cells what they are supposed to do. But sometimes there is mutations or errors in this code. And so you can see that on top, this is what the code is supposed to look like. It's supposed to be a red T, but an error happened at some point, and now it's a blue C. And that could mean nothing, or that could mean that there was a very important step, and now we forgot to turn the oven on, and we're not going to have a roast beef ready because of this change here. So those changes could be meaningful or not meaningful, depending where they happen and what kind of consequences happen downstream. The genetic testing is looking at the codes, and we do it by collecting a sample from a patient, putting it through sequencing, looking at the code and kind of decoding it. And in the end, we get this code result. And we know that, oh, this is supposed to be a C, but this is a T. So we know this is an error and this is a mutation. And so now going back to PARP inhibitors, what do they do? Well, this is our DNA that has two strands twisted together. And breaks happen. And if only one of the strands break, then it is repaired by PARP. It's kind of a building block that's responsible for repairing the break in one strand of our DNA. PARP inhibitors block this building block. And so the cells are not able to repair it. And when that happens, single strand break turns into a double strand break. And now we have both strands broken. And in a healthy cell, the process called homologous recombination repair takes care of it. And it is done using BRCA1 to an ATM. So those are building blocks to help repair two strands broken. And if cell has those blocks working with no issues, this is repaired and cell goes back into cell cycle, healthy and happy, and continues working as it's supposed to. If this mechanism is not available, such as if there's errors in those genes, or there's mutations in those genes, then the only mechanism available to cells are non-homologous end joining, and that's not a good way to repair it, and eventually leads to cell death because there's a lot of important information missed in that pathway. So PARP inhibitors work in cells that have already one DNA repair mechanism impaired by impairing the second one and eventually leading to a cell death. And so a lot of data on PARP inhibitors is actually in the cancers in both prostate and outside of prostate that have those genes mutated, BRCA1 to an ATM. However, there's a biological rationale to think that AR-targeted drugs such as enzalutamide actually suppress those building blocks And maybe combining PARP inhibitors and those AR targeted agents could help treat cancer more effectively. So the next two studies ask this question. Can we just take all comers, not only the one that have mutations here, but everyone with prostate cancer, give them PARP inhibitor and AR targeted agent and see if that's going to be more beneficial than the standard of care that we have right now. So the first study is PROPEL study. It's a phase 3. It's randomized and double-blind, and an enrolled man with metastatic castration-resistant prostate cancer who were treated with docetaxel was allowed, but no prior abiraterone. And they were on androgen deprivation therapy and had a good performance status. And they didn't look at their mutation status, it was all comers. So first line, metastatic castration resistant, patients were randomized to either receiving abiraterone plus olaparib, which is a name of a PARP inhibitor, or abiraterone plus placebo. And the primary endpoint, the first question the study asked was, again, this progression-free survival. Does this olaparib, adding olaparib helps with progression-free survival? And the second question they ask is survival. Does it help men live longer? And PROPEL showed that in overall, all patients that came in, there was improvement in progression-free survival. So the median progression-free survival, so 50% of men in olaparib arm did not progress for 24.8 months versus 16.6 months in placebo plus abiraterone arm. And once they enrolled the patients, when they put them on the study, kind of retrospectively said, well, now let's go ahead and see whether or not those men had mutations. And in a retrospective look at the mutations, you see, we call those forest plots. They show that the benefit was for both those who had mutation and those who did not have mutation. So as long as those two horizontal lines don't cross this vertical, we consider them, both of them, having benefits. This is overall survival data. It's not mature, but we see that maybe there is a little bit of separation of those two curves at the end, and we're going to have wait for more data to come out if that's going to turn out to be true or not. Adverse events. On the left, you see olaparib. On the right, you see placebo. And overall, 97 versus 94%. In olaparib, the most common side effects of olaparib are anemia. You see more anemia, fatigue, and a little more of GI upset because this is an oral drug. Now, so the first study looked at all comers, adding PARP inhibitor to abiraterone and showed progression-free survival benefits. So this is our first PROPEL study. Now moving to magnitudes. Very similar, but yet different study. Looked at, again, similar patient cohort, metastatic castration-resistant, first line, good performance status. But in magnitudes, they decided to look at mutation status to begin with. And so they looked at mutation status for all the patients, and they divided them in those who have the mutation in one of the genes and those who do not have a mutation. So biomarker positive or biomarker negative. And then they randomized each of those patient groups to either receiving PARP inhibitors plus abiraterone, and the name of PARP inhibitor here is niraparib, or placebo plus abiraterone. And so they first looked at the biomarker negative cohort. And in biomarker negative cohort, they did not see progression-free survival benefits. And they concluded that they didn't see a benefit in this patient cohort, and they closed that arm of the study. So a little different from what the first study showed. And we'll discuss nuances of that at the end. And then they looked at biomarker positive cohort, and they showed improvement of radiographic progression-free survival. And they showed niraparib was 16.5 months of median. So meaning men in this arm, half of them did not progress for 16 months versus 13.7 months in placebo arm. They then looked at a subset of those biomarker positive BRCA1 and 2 mutated patients. And the reason they looked at them is twofold. First of all, we do know that BRCA1 and 2 mutations are associated with a more aggressive prostate cancer phenotype, and those patients usually have worse outcomes. And second of all, we know that those patients are usually more sensitive to PARP inhibitors. In the studies that we've done in prostate cancer and other cancers, usually the ones that have errors in these particular genes respond the best to PARP inhibitors. And so the magnitude of benefit was even more significant in BRCA1 2 mutated cancers, 16.6 versus 10.9 months. So what do we do with this data? We have two studies, PROPEL and Magnitude, both phase 3, randomized placebo-controlled, both in first line of metastatic castration-resistant prostate cancer, both using PARP and abiraterone, both looking at progression-free survival as a primary and asking survival a question as a secondary endpoint, but a little bit of conflicting results. And I don't think there is an easy answer, but the time will tell. And I think we do need to wait for the survival data to come out. And we do need to more of a subset analysis to see which mutation carriers responded, who didn't, to understand a little more which patient cohort will benefit the most of this combination therapy. In the meantime, while we're waiting on more data to come out, I don't think abiraterone plus olaparib is a new standard of care for all comers. I do think we need to wait for this survival data to come out. I also don't think niraparib plus abiraterone is a new standard of care for everyone who has mutation in one of the genes. Again, I think survival data and more of a subset analysis needed for us to understand better which patients will benefit from the combination therapy. However, when we look at BRCA1 and 2 mutated cohort, I think it's reasonable to start having those conversations with patients in the clinic because A, we know that those usually are more aggressive cancers, and starting targeted therapies early on can really help improve outcomes in this patient cohort. And B, we know that those cancers and those tumors are usually the more sensitive to PARP inhibitor treatments. So as far as clinical implementation, I think the only way it's applicable right now is for men who have mutations in BRCA1 and 2, have first-line treatment for metastatic castration-resistant prostate cancer, and it's reasonable to discuss it with them. And we don't have a lot of time left, so I'll go really fast and briefly about Pcma therapy. I'll talk about both imaging and therapy. So what is Pcma? Pcma is a protein on the surface of a prostate cancer cell. So you see this is a membrane of a prostate cancer cell, and this is the extracellular. So on the surface of the cell, there is this protein. And if we can find molecules to bind to this protein, we can either mark those cells up and make them light up on scans, or we can deliver treatments to those cells. And so kind of do those really targeted treatments to the prostate cancer cells. And now we have FDA-approved options for both. So Pcma PET scan is a scan that uses a tracer that has two things. One is a radio tracer, something that lights up on the scan. And the second part is a Pcma target. So it's radio tracer that lights up attached to the target that goes and attaches to the prostate cell. And you can see on the bottom, there's two scans, the regular PET scan, and you see just cells that eat a lot of glucose. And on the right, you see much more disease. Those are Pcma PET scan. So things light up that actually have Pcma on them. And you can see there's a lot of disease in the liver. And now there's two FDA-approved tracers for those scans. Gallium-68 Pcma PET scan that was FDA-approved in December of 2020. And F18 DSF PYL, or Pylarify, that was FDA-approved in May of 2021. And at ASCO, there was presented a data from phase 3 Spotlight study that used a new tracer, F18 RH Pcma 7.3. And the reason you have those different numbers and letters to those PSMA targets is because there's different places that tracer can attach. And so even though they all attach to PSMA, they can attach to different parts of it. And that could give different properties to the tracer. And so Spotlight looked at this new scan in men with biochemical recurrent prostate cancer, those who had surgery radiation and have their PSA rising, and they looked at the detection rates. And overall detection rate was 83%. And it varied depending on the level of PSA, with being 100% with PSA above 10 and about 64% with PSA less than 0.5. So the higher the PSA, usually the more sensitive our PSMA PET scans are. So we'll await if this new tracer will get an FDA approval, become commercially available, and if we might be using this new target for therapeutical development. And the last trial I want to talk about is Vision trial. That's a little bit of old news, was presented last summer, but just got FDA approval. So I want to give you a brief reminder. This study used lutetium Pcma therapy. So we have, again, the Pcma target attached to radioisotope. So now we deliver kind of this radiation to those cancer cells. This is a drug that's given IV. And in the Vision study, they included men who progressed on at least one AR-targeted agent and at least one line of chemotherapy. And that's going to be important because that's what went to the FDA label. That's what FDA requires for men to go through before they get the lutetium Pcma therapy. And then men on the study were randomized to lutetium Pcma plus standard of care or just standard of care. And lutetium improved overall survival, median 15 months in lutetium versus 11.3 months in standard of care alone arm. Looking at side effect profile, we can see that there was more bone marrow suppression, more white cell suppression, red cell suppression, platelet suppression, and there was also more dry mouth. It happens to be that PSMA expressed not only prostate cancer, but also in salivary glands. So that's an unfortunate side effect of lutetium therapy, that it causes a dry mouth because it affects the salivary glands. And so based on the Vision study, we have FDA approval for lutetium Pcma. Pluvicto is the name for this treatment that was approved on March 23rd of 2022. And we're hoping that it's going to be available for our patients across the country soon. Thank you so much for your attention. I'll be happy to address any questions you might have.
Great. Thank you, Dr. Sokolova. Great information. We will now go to questions from our audience. Just a reminder, if you do have questions, go ahead and put those in the Q&A box at the bottom, but we do have a few already. One is, what mutations besides BRCA1 and BRCA2 are on the list for further investigation for prostate cancer?
Those are a really good question. I think there's a lot of exciting research happening. If we think about this pathway that we talk about, DNA repair pathway, then the mutations that were involved in the study that led to PARP inhibitor were BRCA1 and 2, ATM, CHEK2, PALB2, and a few others. So I think there's a lot of research understanding, well, which of them are going to have a better PARP inhibitor response, which would not be. There's also a lot of exciting data happening around PTEN deletion. That's quite an often alteration in prostate cancer. And we know it's associated with their more aggressive behavior. There is several studies looking at, can we target it by targeting kind of AKT inhibitors or AKT MI3PK pathways. So I think those research inside is going to come out as well. PT53 and RB1 are also meaningful mutations. We're looking into how we can target them and how we can improve an outcome of those men. I'm not sure this is kind of a prime time yet of that's going to come out. So I would say this homologous recombination is important, and looking at PTEN, CDK12 mutations, something that has been happening and ongoing research as well.
Another question, a couple related to LU177, which I heard you mention some. Question is, what milestone must be met to get the latest treatment in LU177 treatment? This person has been on ADT for a while and had a prostatectomy.
Yeah, so as I mentioned, for now, the FDA label uses the same criteria as Vision study did. So metastatic castration-resistant prostate cancer that has progressed on at least one line of androgen receptor-driven therapy, so abiraterone, enzalutamide, or a cousin drug, and at least one line of chemotherapy, cabazitaxel, docetaxel. There are a lot of studies happening that look into moving this treatment earlier on in the first line or hormone sensitive, but until we have this data, the FDA approval is only for at least third line in metastatic castration-resistant prostate cancer.
Someone asks, and if you have a successful prostate surgery, is it still possible for the cancer to metastasize? They're going to have laparoscopic robotic surgery next month. Currently, it's localized, though.
That's a complex question. When someone is offered prostatectomy, the goal is to cure, and the goal is to treat it, and hopefully the cancer will not come back. However, that's not always an achievable goal. And the success rates really depend on a lot of clinical factors. What is the PSA? What is the Gleason score? Do we think there is any extracapsular extension? Do we think there is lymph node involvement? So and that's why biochemical recurrence disease state exists, is because unfortunately not always we're able to achieve the cure, and sometimes cancer does come back. It's a little challenging for me to comment on the chances of that without knowing the rest of the clinical data.
So this one, regarding the patients selected for these studies, for those patients that initially had radiation, at what PSA rise do you make the determination they actually have BCR locally or metastasized?
That is a very good question. And the level of PSA that we choose to define biochemical recurrent depends on what treatment patients had. And if someone had a radical prostatectomy, we assume that all the healthy cells that are making PSA that are in the prostate are gone. And so if there is any level of PSA after the surgery, we assume that this is from prostate cancer cells. So for those who had surgery, the definition of biochemical recurrence is detectable PSA. You need to have 2 of them within 2 weeks. For those who had radiation before, there still could be some healthy prostate cells left behind. So there could be a level of PSA that does not mean that you have recurrence per se. So for those who had radiation, the definition is PSA of 2 above the nadir. So we see how low PSA went and we watch it. And when it starts rising, if it's 2 above the lowest when it has been, that's what we use as the definition of biochemical recurrence.
What genetic testing or screening should a prostate cancer patient seek out or ask for? Is there one particular test that captures the broadest collection of potential genes to screen for?
Well, this is genetic testing. Prostate cancer is my passion, so I can talk for hours about that. But to summarize,
we have minutes.
To summarize it, there are 2 types of genetic testing. One type of testing is where we look at mutations that happen in the tumor. And we do it either on a biopsy or by using the blood sample and tumor DNA in the blood sample. And we call it somatic tumor testing NGS. That's one type of testing. The second type of testing is looking for something that men are born with, inherited DNA mutations. And for that, we use either saliva or we use blood. And everyone who has metastatic prostate cancer is eligible for both and should have both tumor testing and germline testing. When we think about localized disease, the NCCN recommends germline testing for those who have high risk or very high risk disease, because they are more likely to have germline mutations. Also, all men that have Ashkenazi Jewish ancestry, or those who have a family history that's suspicious with a familial cancer diagnosis, regardless of what stage of prostate cancer they have, are eligible for germline testing, those inherited testing.
Another question, there were, like I said, there were a few on LU177. So where that has been used longer in other countries, have they moved into treatment earlier, such as hormone-sensitive patients with this treatment?
I believe that it's still in the studies. There are several studies looking in Australia and Israel, and it's true that other parts of the world were a little ahead and used it longer, but I do not believe there is an approved label in an earlier stage in anywhere outside of US.
And when you say the tumor is sensitive to treatment, does that mean the treatment has a positive impact? So in other words, please define the meaning of sensitive for the tumor.
Sensitive means that our treatment is working into kind of stopping and pausing the growth of the tumor. And the way we clinically evaluate is we'll look at PSA, if PSA going up or down. And if it's going down, it means the tumor is sensitive. And number two, we'll look at imaging. Does the tumor get smaller? Do we have new tumors happening? And then we'll look at how a patient is doing. Is his symptoms better? Is he feeling better? So when I say tumor sensitive treatment, meaning that our treatment helped to stunt the growth of this tumor, and meaning the PSA is going down, the imaging is looking better, and patient is feeling better.
I think one question that I'm wondering too is, all of this is, that you've presented here, and I think this is all we have time for probably tonight. But all of this information is from recent clinical trials, right, that you're presenting. Of course, we wouldn't have any of the treatments we have without clinical trials. So how do people really start the conversation with their doctor? And especially some of these people would have probably, these clinical trials have been going on for years in some cases. So, and we're just now getting the results. So how does somebody have the conversation now if they're interested in clinical trials? Even early on, a lot of what we talk about with clinical trials is for advanced disease, but even early stage, how do, what's your best advice for patients when they're talking to their doctor about clinical trials and what options may be right for them?
Well, I think the first step is just kind of have this conversation with the provider, because not each cancer center or cancer treatment place will have clinical trials. So just to asking you, do you have any clinical trials that I could be eligible for? And if the answer is no, the second question, are there any other cancer centers around by that I should look into that you think that might have a clinical trial for me? And often oncologists are very open to referring for second opinions to larger cancer centers that might have clinical trials available. So I think the bottom line is never be hesitant or afraid to ask for a second opinion. Ask for a referral to a bigger center. None of providers take it personally. We all work together. We all want the same. We want a patient to feel better and do better. And seek the second opinion, seek the kind of larger cancer centers, talk to your provider about what clinical trials could be open for you.
Okay, great. That's really helpful advice. And I had dropped into the chat earlier. We've got information on Xero's website on clinical trials, including how to find them. So there's a link there for the chat for those of you interested. Well, thank you so much, Dr. Sokolova, for a really informative presentation. To close our webinar today, I want to remind everyone that Xero is here with support that is offered at no cost for both patients and caregivers, and you can learn more at our website at xerocancer.org. This is the conclusion of tonight's webinar. As a reminder, you will receive an email with a link to this recording and a short survey to share your feedback. Thank you for joining us, and have a good evening.